ना.
जयश्री मॅडम दिसतायत का? रुची आहे पण जयश्री मॅडम दिसते मला.
ठीक आहे, प्रोग्राम चालू तर करा, तिला फोन करू आपण.
पण सुरू करूयात.
वैशाली, तुझा आवाज
फोन
क्रॅक
करशील
होतोय.
त्यांना?
मानसी चालू कर तू.
Okay. So good evening, everyone. I welcome you all for the FOGSI ICOG HORMONY web series on
हो, मानसीच चालू करणार आहे सर. मी गाडीत आहे आणि
चालू केलंय आम्ही, तू आता बस सांगतो.
endocrinology in women in association with the Endocrinology Committee FOGSI. This is the 7th episode of the series. At the outset, I would like to ask Dr. Chaitanya Ganpule, the Chairman, Endocrinology Committee FOGSI, and the convener of this program to welcome us all.
Thank you, Manasi, and a warm welcome to all of you on behalf of FOGSI and ICOG. At the outset, I would like to thank FOGSI President Dr. Sunita Tandurwadkar, Secretary General Dr. Suvarna Khadilkar, ICOG Chairperson Dr. Parag Biniwale, and ICOG Secretary Dr. Sarita Bhalerao Madam for giving us an opportunity to join hands with ICOG and develop this webinar series on endocrinology in women. As Dr. Manasi said, we are in the 7th episode of this, and we would like to continue with this webinars even in the next year under the ICOG chairmanship of Dr. Sheila Mana as well. Thank you once again, and I welcome all the speakers for this webinar series, and I request Dr. Manasi to take over and carry on with the proceedings. Thank you so much once again.
Thank you, sir. Now I would like to ask Dr. Parag Biniwale, Chairperson ICOG, to address all of us.
Thank you, Manasi. Good evening, all. I bring greetings from ICOG, and it's indeed a pleasure to welcome you for this episode of Harmony. Let me appreciate the efforts put in by the Endocrinology Committee, led by Dr. Chaitanya Ganpule, the chairperson, Dr. Vaishali Kordinayak, who's the co-convener of this program, along with all our brilliant coordinators, Manasi Naralkar, Mansi Sharma, Madhu Juneja. They are doing excellent work because continuing this activity is so important. And I must thank the speakers and the chairpersons today, Dr. Ruchi and Dr. Jayashri, who are the speakers today. I'm sure this session will be interesting one. And thank you, Chaitanya and team, for collaborating with ICOG. And I hope this activity continues even in the future. Thank you.
Thank you, sir. Today we also have with us Dr. Sarita Bhalerao, Secretary ICOG. Madam, can you speak a few words, please?
Thank you, Mansi, and I take this opportunity to congratulate Dr. Chaitanya Ganpule, Dr. Vaishali Korde Nayak, and the entire team, Dr. Mansi Naralkar, Dr. Mansi, and Dr. Madhu. And I think this is an excellent series going on. I think each episode is really giving us a lot of insight into reproductive endocrinology. So without further ado, I wish all the very best. Thank you.
Thank you, ma'am. I will now like to welcome our chairpersons for today. We are honored to have with us Dr. Meena Armo. She is from the Government Medical College, Rajnandgaon in Chhattisgarh. And Dr. Sasmita Swain. She is the professor and HOD in the Department of OBGY from Cuttack. Dr. Meena and Dr. Sasmita are very senior teachers, and we are honored to have them here today. I would also like to welcome the speaker for the first session. The topic for the first session is classification of menstrual disorder, which would be delivered by Dr. Ruchi Thakur, who is a senior consultant in Apollo Hospitals, Pune. Madam, I hand over the floor to you now.
Thank you. Thank you so much, Mansi. I would like to thank the organizing committee for giving me this opportunity to share a few thoughts about menstrual cycle disorders. So I think I should start without much ado. I'm sharing the screen. So, as we know, the cycle disorders have a major impact. Their prevalence worldwide has been found to be around 3 to 30%, and approximately one third of women are affected at some time in their life. Only last month we came to understand that the Karnataka government has in fact started to give, they have passed a motion wherein they will be giving menstrual leave, a paid leave of 1 day per month. So a woman will be having around 12 paid leaves in a year because of the menstrual cycle disorders that the women suffer from. So it's not something that is very small. When it is affecting the quality of life and the work related issues, then it becomes an important thing which needs to be addressed in a systematic, methodical manner. So, for easy interpretation of investigations and evidence-based clinical care, FIGO designed two systems. So, the first system is based on the terminology and definitions. As we know that the terminology and the definitions were very ambiguous. Terms like menorrhagia, hypomenorrhea, oligomenorrhea, these were being used. So, these terminologies now have been discarded and new terms have been inculcated. Another thing, for the first by the first system, we divide according to the symptomatology that the patient tells us. The further stage is the second system. The FIGO AUB system second comes into play once we are through with the symptomatology, which gives us an idea whether it's a structural abnormality that we are seeing or whether it's a non-structural abnormality, followed by which we investigate it methodically according to the algorithm provided by FIGO, and treatment is then offered to the patient. So the contemporary systems that we are talking about were designed by Malcolm Munro along with his team, and as recently as 2023 August, this is from where I have sourced my lecture. So chronic non-gestational AUB is defined. Again, we divide it into acute and chronic. Chronic is when there is abnormality in the duration, the volume, the frequency, and the regularity, and this has been present for preceding 6 months of a patient's life. We call it as chronic. Whereas acute is just an episode of a heavy bleeding that is of sufficient quantity to require immediate intervention to minimize or prevent further blood loss. So based on the temporal frequency of the complaint, we divide it into acute and chronic. Now, the FIGO system AUB addresses 4 criteria. First is the duration of the menstrual cycle. Second is the volume of the blood loss. Third is frequency. And fourth is regularity. Regularity has variation of 7 to 9 days depending upon the age. If the patient's age is between 18 to 25, then regularity, we consider it regular if it is within 9 days. In 26 to 41, this criteria is less than 7 days, and in 42 to 45 years of women, it is less than 9 years. So now, according to the parameter, it is, as I pointed out, frequency. When there is no bleeding, we call it as amenorrhea. Infrequent is if it is more than 38 days. Normal frequency is from 24 to 38 days, and frequent is if it is less than 24 days. We call it prolonged if it is more than 8 days. Regularity is, as we have discussed earlier, based on age. Longest cycle variation of 7 to 9 days, and shortest to longest variation of irregular is more than 8 to 10 days. Then flow and volume, light, normal and heavy, which is determined by the patient. Another term that we are using is intermenstrual bleeding, which might not be present, which might be random, or which might be cyclical. It might be early, it might be mid-cycle, or it might be in late cycle as well. Early cycle intermenstrual bleeding is normally seen in isthmoseals. Unscheduled bleeding on progestogen and estrogens or gonadal steroids if the patient is on oral contraceptive pills or on rings or patches or injections. It might be present or it might not be present. So this is the standard terminology by which, taking into account the 4 criteria, we define it as normal and abnormal. Please note it also takes into account absent or no bleeding or amenorrhea. Once we have understood the symptoms of the patient, then we divide it according to the FIGO system 2, whereas PALM, as we all know, describes the structural abnormalities, which could be polyp, adenomyosis, leiomyoma, malignancy and hyperplasia, or it could be non-structural like coagulopathy, ovulatory disorders, endometrial disorders, iatrogenic, or not otherwise classified, which includes bleeding like AV malformation. So this is how we have to segregate the causes of bleeding. Very common cause is leiomyoma, which is again divided into various types based on their location, whether they are intramural, subserosal, and the amount of the leiomyoma, which is less than 50% or more than 50%. We all know about this. So this is how we describe the leiomyomas. So now we have to understand that a woman who is presenting with AUB might present with a single entity, or it might be a number of factors or number of things that coexist together, and then they show a spectrum of symptoms. So accordingly, we have to divide. Now here we have this Palm-Cohen classification along with yes, no, and where it has not been investigated is demarcated by question mark. Okay, so suppose we come to understand by ultrasonography that the patient has leiomyoma type O. So we mark it here in the yes column. In the yes column it is marked, and rest of the things are delineated or ruled out, like there's no polyp, there is no ovulatory disorder that is found in a patient. But yes, there are few things which we have kept in undetermined column, like we don't know whether there is endometrial pathology is involved or not involved, or whether it is coexisting with coagulopathy or not. Once the investigations have been done, then we come to understand that yes, endometrial hyperplasia is present as well. So these two are marked at yes, whereas the coagulopathy comes under no. So this is how we come to understand that the diagnosis in a particular patient is leiomyoma 0 and endometrial hyperplasia coexisting with this. So these columns are of, they are very easy to make and they give us very precise diagnosis. Now, how do we proceed? Clinical application of what we have learned till now. So how do we assess these patients? Menstrual general assessment includes menstrual history, which should be taken in great detail. Understand that we will be applying the type 1 classification based on the symptomatology and the history, which gives us proper findings. After that, look for symptoms of anemia, sexual and reproductive history. Yes, it's always good to understand the future fertility desire in the patient if she's having subfertility, because it changes the direction of treatment completely. What are her current contraceptive requirement can also be discussed during the history. Besides this, associated symptoms also point towards the diagnosis, like bowel or bladder symptoms in particularly give us an idea that probably pressure symptoms are occurring. Weight, systemic changes are equally important. Specifically, you should also try and rule out the coagulopathy history in these patients, especially in patients who are not on antiplatelets or on anticoagulants. So, what are the pointers towards coagulopathy history in these patients? The first thing is heavy menstrual bleeding since menarche, if the patient is telling us about this, or she has a positive history of one of the following: excessive postpartum hemorrhage, surgical related bleeding wherein she required blood transfusion, or bleeding associated with dental work. Another criteria is two or more of the following symptoms like bruising 1 or 2 times per month, epistaxis 1 or 2 times per month, frequent gum bleeding, and family history of bleeding symptoms. So these are the patients in whom we should go ahead with coagulopathy screening. And these are the important pointers in history which point towards a coagulopathy. Now, once we have established that it is chronic AUB with more than 3 months of excessive bleeding, volume, duration, then the initial investigations include structured history, physical examination, and ancillary investigations. In structured history, if we come to understand about the ovulatory dysfunction, we should discuss about future fertility. Related disorders, which I have already shown in earlier slides, should also be ruled out, and important patients should be screened for inherited coagulopathy. Ancillary investigations include complete blood like hypothyroidism, hyperprolactinemia, all the diabetes. These should basically be included as well. Testing for inherited coagulopathies if it is indicated by the history. Then we come to the uterine evolution. So we talk about enhanced risk of hyperplasia or neoplasia in these patients, or probably of a structural anomaly. So if there is endometrial hyperplasia, you are seeing a raised ET on TBS, you can go ahead with endometrial biopsy. If the specimen is adequate, then you would have a histopathological report in hand, which can further guide further management. If the specimen is not adequate, in this situation, it is better to go ahead with hysteroscopic directed biopsy, taking the biopsy of targeted lesion. If you are able to assess it well, well and good, you will reach a diagnosis. In case you are not able to assess it well, go ahead with further imaging. Consider further imaging things. In this situation, contrast sonohysterography can also help in ruling out polyps and submucosal fibroid to an extent. So this is how we proceed ahead with clinical assessment of anomalies. Now, for example, here we take a case. In this case, ultrasonography, sonohysterography showed a small polyp. So this patient was then posted for hysteroscopy, where we saw a polyp as well as a fibroid was also seen during ultrasonography. So the diagnosis came out to be a polyp which was coexisting with a leiomyoma. Endometrial polyp along with leiomyoma type 5 was the diagnosis, and accordingly the management can be done in these cases. Second case that I would like to illustrate is cycle length of 14 to 60 days, irregular cycles, regularity plus minus 46 days, duration was also high, 2 to 11 days, and volume was normal to heavy, and there was intermenstrual bleeding as well. So after investigations, it was found that there was endometrial hyperplasia as well as a type 6 fibroid. So again, a diagnosis was made of ovulatory disorders along with L5. based on FIGO 1, which is applied very well over here, as well as FIGO 2. So this is how we have come, not endometrial hyperplasia, it's ovulatory disorder. So this is how we come to understand that this is leiomyoma along with ovulatory disorders. Besides this, disorders of ovulation, now FIGO has also come up with disorders of ovulation, which will be classified in a separate manner. So there is an entire spectrum that exists with an occasional failure to ovulate to something serious, which is occasional ovulation, which can ultimately lead to an ovulatory cycle. So this is the entire spectrum which is now coming under focus. Following this is the proposed FIGO ovulatory disorder classification, which goes by HYPO-P, which is type 1, that is hypothalamic, type P stands for pituitary, O stands for ovarian, and PCOS is classified entirely differently in a type 4 category. They are again subdivided into gain fit pie, which includes genetic causes, autoimmune causes, iatrogenic causes, and neoplasms. Fit includes functional causes, infectious causes, trauma and vascular causes, and pie includes physiological, idiopathic, and endocrine causes. So this is all about the classification of menstrual cycle disorders. Thank you for a patient listening.
Thank you so much, ma'am. I would now like to ask our chairpersons to address the question and answers and say a few words.
So, thank you, Dr. Ruchi.
Thank
It is a very really and very nice description of each and every aspect of the menstrual disorder. And as we all know, menstruation is a very important from history itself. If taken properly, we can diagnose almost many diseases, gynecological disorders. So it is very important to understand the menstruation and its how to take its history and how to apply it in diagnosing in our diseases. So thank you, Ruchi, for the very crispy and very detailed FIGO classification, everything you have described. So thank you.
you.
And I once again thanks the organizers, Parag sir, and Ashok sir, Chaitanya Ganapula madam, Sarita madam for giving me this opportunity to chair this prestigious FOGSI ICOG Harmony webinar. Thank you again. Ruchi has also another one and a beautiful session on catamenial seizures.
Yeah.
So
So before moving on to the next talk, Dr. Sunita madam has joined the webinar today. So I would like to welcome her, President of FOGSI for the year 2025. Welcome, madam, and I would like her to say a few words.
Hi, Chaitanya. And it is always great pleasure to join whenever the ICOG classes are there. With you, the endocrinology, I was listening to the previous while I was doing my consultation, and it was beautifully, she has covered basics very well. And the consistency with which ICOG works, I think I need to congratulate the entire team. Thank you so much.
Thank
I don't want to take academic time.
Thank you, madam. Thank you. Thank you. Mansi, I think Dr. Gajaraj has, she is a little busy with some emergency. So we will move on to Dr. Ruchi's next talk. By the time we finish with Dr. Ruchi's next talk, if she joins, we will take that talk, or else we have to reschedule it for the next session.
another thing, I think the menstrual is the FIGO classification, the hyperplasia is included in malignancy. Palm coins malignancy,
Yeah.
hyperplasia they have included. Yes.
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 Yeah. Dr. Ruchi, can I request you to go ahead with the next talk on catamenial seizures as well?
Yes, I'll do that. Yes. I'm sorry, I'm not able to go. Just give me a minute, please. Just should I start?
Yes, please, madam.
Should I start?
Yes, madam.
Yes, Ruchi, please start.
Thank you. So the next topic that I am covering is catam. Yes, ma'am. The next topic that I am covering is catamenial seizures, in which we will be talking about how the epilepsy occurs and how it is affected by the menstrual cycle. So catamenial seizures doesn't
Can you
mean that
see the slides?
No, sorry to interrupt you, madam. Just
yes.
share your presentation. Yeah, just share your presentation. So to Ruchi ma'am, just share your presentation.
Yeah, now we can see the screen. But yeah.
Yes, ma'am, go ahead.
Okay, so now I'm starting with my talk on catamenial seizures. In catamenial seizures, the thing that we have to understand is that they are not a new onset seizures that are brought about by the menstruating woman. They basically are exacerbation of seizures that already occur, that are already existing in an epileptic woman, and they have various transitions according to the phases of the menstrual cycle. Okay, so based on the hormonal changes that occur, the amount of estrogen or progesterone that changes or variates during the various phases of menstrual cycle, there is increase in the epileptic activity or seizure activity. So, specifically in women, adult women who are menstruating, this is an issue that is faced by many of the women. So, catamenial, the word itself is derived from Greek word katamenios, which means monthly, and it describes a seizure pattern that correlates with 4 phases of the menstrual cycle. They occur secondarily to the neuroactive properties of endogenous steroid hormones, and there are natural cyclic variations activity remains quiet during other phases of the cycle. So, sex hormones, as we'll just go quickly through the physiology. Sex hormones, conditions, and catamenial seizures are seen in reproductive aged people who menstruate with any seizure syndrome. There is a twofold increase in seizure frequency during a specific period in menstrual cycle, and this is how we diagnose catamenial seizures. Increasing by twofold, we say that they are probably catamenial seizures. The prevalence of catamenial seizures is around 44.2% in women with epilepsy. So basically, estrogen is a pro-convulsant hormone and progesterone is the anti-convulsant hormone. The two metabolites that we normally talk about are estradiol, that is E2, and P4, progesterone or allelinolol. So E2 activates the NMD receptors and it suppresses the GABA receptors, causing excitatory stimulus. So whenever in the cycle the amount of estrogen is more, then the pro-convulsant activity is more. And progesterone acts through its P4 metabolite, which stimulates the GABA receptors, and these GABA receptors cause neuronal membrane stabilization. So basically, in what I would like to point out is that progesterone is anticonvulsant and estrogen is proconvulsant. So the of cycle where estrogen is raised are bound to increase the epileptic activities. These are continuing despite traditional anti-epileptic. So this is how we have to address whether the seizures are continuing despite traditional anti-epileptic drugs. Are the seizures occurring in cyclic fashion and noted an increase in seizure activity during particular period? So in order to understand, we have to very clearly ask these questions and address these questions. So even if she's on anti-epileptic drugs and despite that if she's having convulsions, then this is worrisome. Another thing is cyclical variation, and another thing is we correlate this cyclical variation along with her menstrual calendar. So keeping a menstrual calendar plays a very important role. So this is a menstrual calendar where this can be kept very easily. In order to assure that she has reached a post-ovulatory phase, this will help us define the seizure activity according to cycles variation more clearly. And serum progesterone measurements can also help us with more clear diagnosis. So based on the cyclical variation, we divide catamenial seizures into three types. The first type is the perimenstrual type, which is characterized by rapidly reducing level of progesterone during menstruation, that is from day 25 to day 3 of the following cycle. So this is a period C1 type of catamenial seizures where it is very much increased. Peri-ovulatory subtype is characterized by rapid surge of estrogen from days 10 to day 15 of her cycle. Again, the seizure activity is increased at this time and we label this as type C2. Type C3 is when there is inadequate luteal phase and it is characterized by inadequate rise of progesterone during the luteal phase, that is from day 10 to day 3 of the following cycle. So these are the three subtypes which very well depict the variations that are occurring, and all of these are basically characterized by reduced progesterone and somewhat increased estrogen. So here we can see very clearly this graph shows the diurnal variation very well. So here you can see that the estrogen and progesterone level is less, and this is the type C1 that you are seeing. Then C2 is during the peri-ovulatory phase when again there is increase in the estrogen. And type C3 is inadequate luteal phase. This is the progesterone level which is inadequate, and the estrogen relatively is more and causing seizure activity. So these are the two types, the C1, the C2 and C3. In C1, the perimenstrual, both estrogen and progesterone have fallen off, but estrogen is still little bit higher. So this causes seizure activity based on the menstrual cycle. So there are two types of approaches. First is the non-hormonal pharmacotherapy. So the patient is already on anticonvulsants, but she's not responding to those anticonvulsants. So in this situation, we think of intermittent benzodiazepines, that is clozapam is the drug of choice. It is started 2 to 4 days before anticipated seizure days and continued for 1 day. It is effective only in C1 and C2 types. That is, it is effective in perimenstrual and periovulatory type of catamenial seizures. It is not effective in inadequate luteal phase type or C3 types. Another drug that can be used is acetazolamide, which is a carbonic anhydrase inhibitor, acetazolamide, which improves axonal stability in brain, and it can be used in all three types, C1, C2, and C3. These drugs are started by neurologists, not by gynecologists. Hormonal pharmacotherapy, this should be considered only and only when the patient is unresponsive to the traditional therapy. One is natural progesterone can be an option for these patients, and specifically for impaired luteal phase cycles. It is normally given in cyclical form during luteal phase, taken orally at the dose of 100 to 200 milligram twice a day. We can also think of medroxyprogesterone acetate, which can reduce the seizure frequency to a longer period. Systemic oral contraceptive pills have not been found to decrease seizure frequency. Even though estrogen is a proconvulsant, combined oral contraceptive pills have not been associated with an increase in seizure activity. So this has to be noted down. So they may be used in women with epilepsy also to prevent unwanted pregnancies. Clomiphene has been found to be of some use. It is specifically used to treat hypogonadism and has been used to regulate menstrual cycle, especially subtype C3, that is with inadequate luteal phase seizure activity are the potential candidates. Long-term use increases risk of endometrial cancer. So this is what was found in the paper that I referred to. GnRH analogs like goserelin and triptologs have somewhat role. They are specifically used for C1 subtypes, but C2 and C3 can also benefit from this. One thing we have to understand is that there will be transient spike in estrogen, and so in this situation, this might lead to bit of increase in the seizure activity, which is then followed by downregulation. So this should be noted. Galexone is a synthetic analog of allopregnanolone, and it is a neurosteroid metabolite of progesterone. It has been shown to have promising activities. Now, how to choose what you want to give? So regularity of individual's menstrual cycle plays an important role. C1 and C2 patients with regular menstrual cycle will respond to progesterone and ganaxolone. And irregular menstrual cycle patients, we should think of clomiphene and GnRH analogs and DMPA. For individuals who have regular menstrual cycle and do not wish to become pregnant, DMPA will have additional benefit of contraception as well. So this is a short table which describes what has to be used where and various dosages in which they should be used and which specific subtype responds to which. So there are other special considerations as well which we should pay attention to, that there are complex metabolic interactions between endogenous steroid hormones, hormonal pharmacotherapy, and traditional anti-seizure medications. We understand that anti-seizure medications are metabolized by the liver. and lot of anti-seizure medications induce enzymes which also increase metabolism of estrogen and progesterone as well. So we have to be vigilant about the possible interactions of all these components, and enzyme inducing anti-steroid medications increase hepatic metabolism of estrogen progesterone, which may disrupt the balance of hormones, and it can also exacerbate catamenial seizures. Concurrent administration of EAISMs with oral contraceptives reduces the efficacy of oral contraceptives, and clobazam, the benzodiazepine, has enzyme-inducing properties, and it should be used carefully in women who are already using oral contraceptives. So this was all about catamenial seizures. Thank you for a patient listening.
Thank you so much, ma'am. That was really very informative. Can I request Dr. Meena, our moderator? Yeah.
Thank you, Dr. Ruchi. It was excellent lecture, and we all know that it's a lesser known topic. So, but each and every aspect has been nicely covered and explained by you. So I don't
Thank
think
you, ma'am.
anybody has any questions. Thank you.
If we have any questions, please feel free to ask them. You can also type them in the chat box. And in the meantime, I will hand over to Dr. Mansi Sharma, my colleague, for the quiz.
Till Mansi joins, Ruchi very nicely covered both the topics.
Thank you, ma'am.
Excellent presentation with what we had thought of that you would be the right person to give this talk. You have proven 200% right, all of us. And
Thank
thank
you,
you so
ma'am.
much.
Thank you for the confidence.
Yeah, and thank you for such a lucid presentation. Look forward to have you again. Thank you.
Thank you,
once
ma'am.
again.
Thank you, ma'am, for such an excellent talk. It was really informative. I think topic related to catamenial seizure is something which we normally don't hear so much about.
Yes.
We really learned a lot today. So we will start with the quiz. In the quiz, I have covered all three topics. So I would request everyone if they could stay back for the quiz. Kushi, can we have the quiz, please? On the screen, there is a QR code. You can join the quiz by scanning the QR code, and there is also the link which is shared. You can also join the quiz by clicking on the link. We have 5 rounds for the quiz, and the topic is the topic of the lectures today. Every round has 5 questions. We will be waiting for 1 minute and then we will be starting with the quiz. If anyone has any problem, link is there, ma'am, in the... Khushi, can you also put the link in the chat box, please, so that everyone can access the link?
Yeah, just a second, ma'am. I need to stop share the screen and then I will
Yeah.
again present
Unfortunately, we couldn't have the third topic, which is PMS and PMDD, because madam is struck in as an emergency and cannot join us today. The link is also shared in the chat box. You can also join through the link. Okay. So I think we should start with the quiz. Let's start with the first round. Okay. The first round for the quiz is a visual round. Can we have the first question for the round, please? Okay. Okay, you have to identify this famous personality, and the hint for this is that she's credited with the introduction or publication of the term PMS in the British Medical Journal in 1953. Whether she's Rosalind Franklin, Katharina Delton, Dorothy Hodgkin, or Nat Stevens. This is one related to a famous personality, which we normally don't read. 2 seconds remaining. Oh, only two of you are correct. The correct answer is Katharina Delton in 1953, along with Raymond Green. Katharina Delton, she published the article and the first term, which is premenstrual syndrome, in the British Medical Journal. Can we have the next question, please? Okay, the chart shown is used to prospectively record the daily physical and behavioral symptoms across the menstrual cycle for diagnosing PMS, PMDD. What is this chart called? Whether it is called COPE, which is Calendar of Premenstrual Experience, whether it is Menstrual Bleeding Pattern Chart, whether it is Daily Symptom Recall Form, or Premenstrual Assessment Scale. Actually, there are a lot of questions which are from PMS. So, yes, 5 of you are correct. That is taken directly from Speroff. So the correct answer is COPE, which is Calendar of Premenstrual Experience for the diagnosis of PMS, PMDD. Can we have the next question, please? Identify this classification. We just saw this slide. It is very easy, whether it is LASMER or Step W classification, whether it is FIGO, whether it is PALMCOIN, whether it is MUSA. I think it's very clear-cut, very simple answer. Ma'am, you have to select the answer. Whoever, you have to tick mark on the answer. Yes, 10 of you are correct. The answer is FIGO classification. Can we have the next question, please? Okay, so this is the graph which shows cycle-dependent variation of PGF2 and PGE2. Which condition does the biochemical pattern represent, whether it is PMS, PMDD, primary dysmenorrhea, or menstrual migraine? There are 1-2 questions which are also related to similar topics. I've given you a hint. The graph, the PGF2 alpha are going very high near the menstruation. Yes, 6 of you are correct. The correct answer is primary dysmenorrhea. Can I have the next question, please? Okay. The uterus with a heterogeneous myometrium, small myometrium cyst, which is Swiss cheese pattern on TVS. What is the most likely diagnosis, whether it is adenomyosis, whether endometriosis, leiomyomas, or chronic endometritis? This is the TVS appearance. Typical appearance with small myometrial cyst on TVS. Patient presents with menorrhagia as well as dysmenorrhea. What is the diagnosis, likely diagnosis? The time is up. Yes, 11 of you are correct. The correct diagnosis is adenomyosis. So this brings us to the end of the round 1. Can I have the score for the round 1? Okay, so after round 1, Naina is on the first position, followed by Madna, Poonam, Dr. Mansi is on 4th position, followed by Manisha. So with Manisha has the longest correct streak. So can we move on to the round 2, please? Okay, so next question for this round is, which of the following best describes the hormonal dynamics in PMDD, whether it is abnormal absolute hormonal values, whether it is the altered sensitivity of the CNS to normal hormonal variation, whether it is the persistent luteal phase progesterone deficiency, or whether it is the elevated LH surge during ovulation? What does the best describes the hormonal dynamics in PMDD? Can we have What happened to that? Okay, we will take it again. I think there was something. So which of the following best describes the hormonal dynamics? I request everyone to please put your answers once again. What is the basic physiology in PMDD? We have 2 seconds remaining. Okay, the times is up. Yes, 8 of you are correct. There is no hormone excess or deficiency. It is the altered sensitivity of the CNS to normal hormone variation, which results in PMDD. So B is the correct answer. Can I have the next question, please? A 24-year-old woman with epilepsy reports seizure clustering around the menstruation, spikes 2 days before, 3 days after menses. Which hormonal pattern most likely triggers the seizures? Whether it is high progesterone, low estrogen, whether it is estrogen withdrawal, whether it is high estrogen or low progesterone, or whether it is constant high estrogen and high progesterone. We just saw this chart more properly in Ruchi Madam's talk. She had shown all the changes. The times is up. Yes, 7 of you are correct. It is C, which is high estrogen and low progesterone, which is most likely triggering the seizure pattern. Can we have the next question, please? Okay, which of the following features favors secondary dysmenorrhea over primary, whether it is onset within 6 to 12 months of menarche, pain limited to first 1 to 2 days of menses, pain persisting throughout menstruation and sometimes beyond, or excellent response to NSAIDs. You have to say which feature is of the secondary dysmenorrhea, not of primary dysmenorrhea. So only one feature is of secondary, rest all are primary dysmenorrhea features. Yeah, the correct answer is C, pain persisting throughout menstruation and sometimes beyond. Can we have the next question, please? Okay, in FIGO AUB terminology, intermenstrual bleeding or IMB is defined as cyclic bleeding occurring less than 21 days apart, bleeding between clearly defined cyclic menses, bleeding more than 7 days duration, or bleeding after menopause. We also discussed this right now. Three seconds remaining. Yes, correct. 11 of you are correct. The correct answer is B. Can we have the next question, please? Okay, which of the following biomarkers has shown consistent alteration in PMDD patients, whether it is decreased allopregnanolone sensitivity, whether it is elevated prolactin levels, whether it is low follicular phase estradiol, or whether it is high cortisol? You have to say which of them is responsible or markedly shown alteration in PMDD patients. Yes, 5 of you are correct. The correct answer is A, which is decreased allopregnanolone sensitivity. In PMDD, there is an abnormal GABA response to allopregnanolone despite the normal hormone level. So A is the correct answer. The sensitivity is, there's a decreased sensitivity. Can we have the scores after this round, please? So the scoreboard there is slight change with Nena, Sharmila, Poonam, Sajala. And Sajala has the longest streak of 9 correct answer, and Dr. Mansi, Manisha and Manna. Can we have the next round, please? We move on to the round 3, and the first question for this round is, which of the following correctly defines DSM-5 diagnostic criteria for PMDD regarding symptom count? It is more than equal to 5 total symptoms with more than equal to 1 effective symptoms, more than 3 total symptoms in any domain, more than 5 physical symptoms only, or more than equal to 2 effective symptoms mandatory. So you have to define what is the correct answer for DSM-5 diagnostic criteria. Yes, 5 of you are correct. It is more than equal to 5 total symptoms with one effective symptom should be there for it to classify as PMDD. Can we have the next question, please? A 36-year present with progressive dysmenorrhea, menorrhagia, TVS reveals bulky asymmetric uterus with heterogeneous myometrium and pan-shaped acoustic shadowing with myometrial cyst. Which standardized USG reporting is used to describe and classify these findings? Whether it is Musa criteria, whether it is WHO sonographic scoring system, whether it is ITA classification, or whether it is a PALM-COIN classification. I'll give you a hint. It is adenomyosis. So what criteria is used to diagnose it? Yeah, 7 of you are correct. It is Musa criteria. Can we have the next question? In primary dysmenorrhea, which statement regarding uterine activity during menstruation is correct? Whether the basal tone decreases to 5 to 10 mm mercury, whether the frequency of contraction decreases, whether the resting intrauterine pressure increases to 80 to 120, or the contraction becomes of low amplitude. Which of these statement is correct? Yes, 8 of you are correct. The resting intrauterine pressure rises to 80 to 120 mm. Can we have the next question? According to FIGO 2018 recommendation, which of the following terms is no longer preferred in classification of menstrual disorders? Whether it is menorrhagia, whether it is heavy menstrual bleeding, whether it is intermenstrual bleeding, or whether it is ovulatory dysfunction. Which term we are no longer using or preferring to use in the classification of menstrual disorder? Yes, 7 of you are correct. We are no longer using menorrhagia. Rest all the terms are used in the FIGO according to the FIGO classification. Can we have the next question? Which of the following neurotransmitter systems is most strongly implicated in the pathophysiology of PMDD? Mind you, we are talking about the most strongly implicated, whether it is dopaminergic, serotonergic, noradrenergic, and GABAergic. So we want the highest or the most common one answer. Okay. I'll correct the confusion. So, 7 of you have written GABAergic. So, that is not wrong. That is correct. But it is not the primary neurotransmitter which is affected in PMDD. In PMDD, the primary neurotransmitter, that's why I stressed again and again and again, it is the most strongly implicated neurotransmitter in the pathophysiology of PMDD is serotonergic, followed by GABAergic. So the correct answer is serotonergic. Can we have the scoring after this round, please? Okay, so after this round, there is slight change in the scoreboard. We have Naina followed by Mansi Naralkar, Sharmila, Poonam, Sajala. With Sajala is still on the longest running streak with 9 correct answer, and Manisha. So we move on to the 4th round. Can we have the, okay. So dysmenorrhea, you have to say which pathway, which of the following drugs interrupt this pathway? Increased prostaglandin leading to vasoconstriction, leading to ischemic pain. Which of the following drugs is best interrupts this pathway? Whether it is combined OCPs, whether it is tranexamic acid, mefenamic acid, or danazol. Very straightforward answer, very clear-cut answer. Yeah, 9 of you are correct. The correct answer is mefenamic acid. Can we move on to the next question, please? Okay. 24-year-old female with primary dysmenorrhea cannot tolerate NSAIDs due to gastritis, and she seeks a contraceptive method which can relieve pain. So most appropriate option will be copper IUCD, levonorgestrel IUS, or condoms or diaphragms. Yes, 9 of you are correct. The correct answer is B. Can we have the next question, please? The most evidence-based first-line pharmacological therapy for PMDD is alprazolam, fluoxetine, drospirenone-containing OC pills, or GnRH agonist. Okay. Again, according to Sperov, they have given a first-line drug as both drospirenone-containing ocipils and SSRIs. But first, they have said that you should try SSRIs first. If not responding, drospirenone-containing ocipils. So I have taken it as SSRIs and fluoxetine as the correct answer. So correct answer is B. Can we have the next question, please? A 19-year-old with severe cramps on day 1 and 2 relieved by NSAIDs and normal pelvic examination. What will be your next course of action? Whether you will do a diagnostic laparoscopy, whether you will do a CT pelvis, whether there is no investigation, or whether MRI pelvis. You have to see she's a 19-year-old female. She has severe cramps on day 1 or 2 of her menses, which is relieved by NSAIDs with normal pelvic examination. What will you do? Yes, 11 of you are correct. No investigation. Can we have the next question? A patient with PMDD with catamenial seizures improved dramatically on a continuous hormonal regime which suppresses ovulation. What is the most likely agent used? Whether it is combined cyclic oral contraceptive, whether it is continuous Dinogest 2 mg per day, whether it is LNG-IUS, or whether it is continuous GnRH analog with add-back therapy. Please take into consideration all the words written there. Can I have the answer, please? Okay. The correct answer is D, continuous GnRH analog. See, the first answer why it is not correct, because it is not combined continuous oral contraceptive pill therapy. We don't want to give any cyclical therapy. We have to suppress the ovulation. So it is there is specifically written that it is combined cyclic oral contraceptive. So we are not going to, this is not the drug which is we have used. Continuous Rhinogest, again, we are not using it because we want to suppress ovulation along with no fluctuations. If we are using LNG-IUS, if we have an add-back estrogen to it, that will be much better choice, not only LNG-IUS. That's why the correct answer is continuous GnRH with an add-back therapy. That's why I said all the words are very important in this. It is a very confusing answer. Can we have the scoreboard with the round after this round, please? Okay. So after this round, the score remains Naina followed by Dr. Mansi, Sharmila, Poonam, and Manisha. With Manisha has 9 correct answers, and we move on to the last round of the quiz. All of the following are used as therapeutic approaches for catamenial epilepsy except natural progesterone supplementation, acetazolamide, intermittent benzodiazepine, combined oral contraceptive with high estrogen. I think Ruchi madam just discussed this, that I will give you a hint, we can use it, but these are not used as therapeutic approaches for catamenial epilepsy. Yes, 9 of you are correct. The correct answer is D. Can we have the next answer, next question, please? Which is not an evidence-based non-pharmacological intervention for PMS, whether it is cognitive behavioral therapy, whether it is calcium carbonate supplementation, whether it is evening primrose oil, whether it is regular aerobic exercise, which does not have a very strong evidence base to it. The rest all we can use as a non-pharmacological intervention for PMS. Okay, the four of you are correct. The correct answer is evening primrose oil. Calcium carbonate supplementation does have some evidence to be of benefit in PMS. So the correct answer is C. Can we have the next question, please? Preferred therapy in C3 pattern seizures exaggerated throughout luteal phase due to anovulatory cycles, lamotrigine dose escalation only, progesterone cyclic therapy, estrogen patches, or no pharmacological therapy. Madam has talked about this right now. This is the luteal phase anovulatory cycles, which is due to specific low progesterone levels. Yes. The correct answer is B, progesterone cyclic therapy. Can we have the next question, please? According to FIGO palm coil classification, which of the following condition is not included under the non-structural causes of AUB? Ovulatory dysfunction, endometrial causes, adenomyosis, iatrogenic. It's very, very simple, very clear. I think it's... So rest all are included under the non-structure. Only one of these is of the structural causes. Yeah, 6 of you are correct. Adenomyosis is from the structural causes. Rest are all in the non-structural causes. Can we move on to the last question for this last round and last question for the quiz? A patient with PMDD does not respond to SSRIs. What is the most evidence-based second pharmacological option? Benzodiazepines during luteal phase, combined OCPs with drospirenone, progesterone supplementation, or TCA antidepressants. Yes, the correct answer this is combined OCPs with drospirenone. So can we have the final scoreboard, please? So we have Naina on the first position, followed by Dr. Mansi, Dr. Sharmila, Dr. Poonam, and Dr. Manisha, Dr. Sajla, and Dr. Mandana. Congratulations to all the winners. And thank you all the participants for participating in the quiz.
Excellent quiz, Mansi. Excellent efforts. It's a very less spoken topic, but the efforts, what you have taken, what you have put in to arrange this quiz, we really appreciate. All the questions were very smart, and our delegates were also attempting it smartly. So congratulations to you and all the delegates. It was really a treat to so much to learn on this particular topic. So we had an excellent session, and we really want to thank FOGSI President who had joined us today, Dr. Sunita Tandurwadkar Madam, ICOG Chairperson, Dr. Parag Biniwale, who has been a constant support for this particular HORMONY series, which we are having with ICOG and the Endocrinology Committee of FOGSI. Dr. Sarita Bhalerao, who had joined for this particular session, and she's always there, always to encourage us. Thank you, madam. Dr. Chaitanya Ganpule, who's the pillar, who is actually the main support and the chairperson of Endocrinology Committee of FOGSI. And we would also like to thank our chairperson, Dr. Sasmita and Dr. Meena, Thank you for your time and your comments. Your wisdom is really important for such series. And the speakers, today Dr. Jayashree couldn't join us because of some sudden emergency what she had just when we started this session. But Dr. Ruchi gave us two valuable talks. One was the classification and the second was on the catamonial seizures, and excellent talks. We had really gained a lot through this particular session. These are the topics which are not even commonly covered in conferences. So I am sure all the delegates have been benefited with this. And I would like to thank Dr. Mansi Naralkar and Dr. Mansi for having this quiz and conducting this program so very well. So thank you once to everyone, and thank you ICOG team for all the efforts which you put in. And we see you next session on the third Wednesday of next month, and we'll bring you the PMS, PMDD session. Along with this, some other important endocrinology topic related with this. Thank you so much. Have a very good evening and enjoy yourself.
Thank you. Thank you. Thank you. Thank you. It was really excellent. Everybody gained from it. Thank you. Thank you.
Thank you. Thank you, madam. Thank you so much. We are good to close, Mansi?
Yes, ma'am.
Yeah.
Thank you.